Let's go ahead and pivot now to the second study, which is called VELIA. The beauty of this study is it introduced a fourth PARP inhibitor into the discussion. We had olaparib, rucaparib, and niraparib. So Shannon, go ahead and tell us about VELIA, also published in the New England Journal at the same time it was presented by this gentleman from MD Anderson Houston.
Heard of him, Robert Holman.
Yeah. We'll let him give the results, but you tell us about the study.
We want to be done in a reasonable amount of time, so I'll give the design.
In the beginning.
So VELIA is a little bit different from PRIMA because we are making a decision right when we start chemotherapy what we're going to do. So this study incorporates Veliparib, which is not a new PARP, but a PARP that does not have an indication yet in ovarian cancer, and it's combining it with standard chemotherapy. So there were 3 arms to this trial. It was randomized 1 to 1 to 1, and there were patients with stage 3 or 4 ovarian cancer, all high-grade serous. They collected things like BRCA, but they were not required. They could be any mutation status, and they were randomized to either standard paclitaxel and carboplatin plus Veliparib in the treatment phase, but then no maintenance, or paclitaxel, carboplatin, Veliparib in the treatment phase, followed by a Veliparib maintenance. And of course, the dosing of Veliparib had to be adjusted. So when we were giving Veliparib with chemotherapy, it was at 150 milligrams BID. And then once we transitioned to maintenance therapy, we could go up to the maximum tolerated dose of 400 milligrams BID. Importantly, the way that this was statistically designed, it was a progression-free survival endpoint was the primary endpoint, but it was a hierarchical analysis, starting with the BRCA mutant group, then moving to the HRD positive group, and then moving to the intention to treat group. So each one of those had to be positive to move on to the next analysis. The number of stratification factors, stage, region, those types of things. And I'm excited to hear about what the results were.
Like you don't know.
Rob, can you start with the exploratory endpoints?
Yeah, we're going to start with exploratory.
Let me carve out the people with left hands, left-handedness. Yeah, so I mean, it's great. And I think just like we heard in the last discussion, we have this HRD group, which is incorporating two cohorts and then the all-comer population. So it's kind of analogous from that design. And you're right, it's we started with an all-comer population. So the way the first 200 patients or so that fit into the BRCA germline or tissue, because both of those were required, and we made that a stratification factor mid-treatment or mid-trial because of what looked like to be an imbalance in one of the arms for the BRCA mutation status. So we pivoted there and made that so that we had a balance across the arms. And so in those 200 patients, we had a PFS of around 34 months on the median compared to around 21 months, and that was a hazard ratio of 0.44, so it was quite significant. And then so the next step down was to look at the total HRD patient population at a hazard ratio of 0.57. Again, about a 12-month improvement in the medians between the group. And then in the all-comer population, we had a hazard ratio of 0.68, obviously statistically significant. And so the hypothesis testing went through that segment, and so the next step will be to do the overall survival. So that's still, we've preserved all of the alpha in the analysis to go into the OS, which of course is we're waiting for endpoints as well. So I think from, as Shannon opened, the kind of the importance here is that this is a decision that's made when you're going to initiate chemotherapy. So it's a very early time point, and so you can use that data to help inform how you're going to write your prescription on day one. And this trial also allowed neoadjuvant chemotherapy. It allowed for dose dense versus Q3 week paclitaxel. And importantly, because toxicity has always been a concern with combining PARP with chemotherapy, the dose intensity that we were able to maintain throughout the entire chemotherapy phase was essentially standard of care dosing.
So, go ahead.
Well, I was just going to comment, I think what's really interesting about this study as well is, compared to the PRIMA study, a larger proportion of these patients were stage 3. It was about 70% or so. And a large proportion of them had surgery to no gross residual disease. So it's kind of a good population.
I think
so. More
kind of
so.
Representative of what we see.
Absolutely, but a little different from what we see with PRIMA, where they favored a lot.
But I wanted to congratulate you, Rob, obviously for the publication and for the practice-changing result. But we needed to check off the box that do we need to give a PARP inhibitor with a DNA damaging agent, chemotherapy? We always wondered that. You were right that you would have to do a dose reduction because there's some overlapping toxicity. And I think we answered that question, that the answer is no, that really the opportunity is mostly in maintenance, right? Okay.
Yeah, I think that, we've learned since we designed the trial was that, this idea of treatment and maintenance is probably super important. We had hoped that we would be able, that maybe we could increase the efficacy during the chemotherapy phase, but I think using progression-free survival is probably not a sensitive enough variable to determine whether or not we are actually adding anything.
And there was an improvement in response rate.
That's right.